I'll be doing case presentation today. Coming to the patient details, it was a 2-year, 11-month-old male child. The informant was the mother, and they were residents from Kodagu, Karnataka. The chief complaints, they came with, the child was brought with complaints of incidentally detected abnormal heart sounds at birth and hurried breathing on exertion since 2 to 3 months. The child was detected to have abnormal heart sound at the time of birth on routine examination, and then the child had no symptoms at that time. The parents were told that the child had a heart disease which required follow-up and may require surgery later. The child was in yearly follow-up, and the child was not given any medications. The child was then gaining weight adequately. The child was playful. There was no symptoms from birth till a few months back. The parents noticed that the child has hurried breathing after playing since last 3 months as compared to his peer group. There's no history of fatigue, irritability, chest pain, no history of syncope, no history of increased precordial activity, no history of sweating over forehead, failure to thrive or lower respiratory tract infections, no history of cyanosis, no history of joint pain or prolonged fever. Coming to the past history, no history of any hospitalizations in the past, no history of surgical procedures in the past. Birth history, the birth weight was 3.5 kg. It was a full-term baby born by LSCS. There was no significant antenatal or perinatal history. Family history, the child was the first issue of a non-consanguineous marriage. The mother's age was 23 and the father's age 32. There was no history of congenital heart diseases or sudden deaths in the family. Coming to the developmental history, the developmental milestones were appropriate for age. Immunization history, the child was immunized up to date as per the National Immunization Schedule. In the summary, it was a 2-year, 11-month-old male child with an incidentally detected murmur at birth on yearly follow-up with hurried breathing since 3 months. So my differential diagnosis I have kept as left ventricular outflow obstruction, that is bicuspid aortic valve aortic stenosis, supravalvular aortic stenosis, and RV outflow obstruction, that is pulmonary stenosis, small VSD or PDA, and hypertrophic cardiomyopathy or VSD with pulmonary stenosis.
So, incidentally detected heart murmur at birth.
Yes.
What does it tell you? I mean, what are the common causes of incidentally detected heart murmur at birth?
So it could be because of any obstructive lesion like AS or PS, or maybe any innocent murmurs are also detected at birth. So it could be any the transient TR or MR, and it can also be because of other like small VSDs and PDAs or any hypertrophic cardiomyopathy.
No, you're telling me all the conditions that you are listed here. So you think small shunts will produce murmur at birth?
Small shunts should not produce murmur at birth.
That's the question I asked you, isn't it?
Yes.
And why not? Why don't they produce murmur at birth?
So as the pulmonary vascular resistance starts dropping, then the murmurs become evident.
Okay.
And this will take about 4 to 6 weeks.
Right.
In case it is larger, then it might be earlier than that.
You think what do you mean? If the defect is large, then the murmur may appear earlier. Is that what you mean?
Larger VSDs and PDAs present earlier than the smaller ones.
No. The question I'm asking you is, we're talking of murmurs being heard at birth. You said small VSDs and PDAs can be heard. But large VSDs, you think large VSDs will be heard at birth or small VSDs will be heard at birth? Or no, none of them will be heard at birth, or all of them will be heard at birth? That's only the...
Sir is asking auscultation, not the symptoms.
Yes.
And it's 2 different things.
By auscultation, it should not be heard, sir, because shunt murmurs only produce murmurs as the PVR drops.
Yes. So the whether small or large, it doesn't make any difference to the occurrence of murmur at birth. Okay. Right. You said transient TR and MR. Okay. Anything else?
Innocent murmurs can be heard, like Still's murmur, and murmur because of pulmonary physiological pulmonary stenosis.
Okay. Now, obviously, this was not an innocent murmur, isn't it?
Yes.
It was continued for 2 years and 11 months.
Yes.
So, what is obstructive lesion? Any other large group you would consider? See, organic incompetence murmurs also present at birth and will persist later on also, no?
Yes.
Organic TR, organic MR.
MR. Yes.
Yes. So,
Yes.
don't say transient MR. It's actually the organic MR which will be heard at birth and which will also continue late at 2 years. Those are the things which will likely to persist. Right?
Yes.
Okay. So you basically have given me a differential diagnosis of all the obstructions: left ventricular outflow obstruction, right ventricular outflow tract obstruction.
Yes,
that's what you have done. Okay.
Yes, sir.
Now, does the history give you any clue that it could be bicuspid aortic valve or supravalvular ES or HOCM and all? Does it give you any clue?
Actually, the history was non-specific. There's only a history of hurried breathing since 3 months. The other thing was the parents were told that there is the child does not require anything as for now, and the child might require surgery later. So, considering this, I had thought of any obstructive lesion.
No, that's okay. I am asking you, does it give you any clue within the obstructive disease as to what it is?
No, sir.
It doesn't. So then you should not list supravalvular ES, bicuspid aortic valve, HOCM and all. There's absolutely no clue that it could be HOCM or bicuspid aortic valve. So your summary at the end of history should not go into so much anatomical details.
Yes.
These are all guesswork. No, you should base your conclusion, historical conclusion, to the extent possible only. I mean, that way you can list everything in the textbook here.
Yes, sir.
That's not the idea of history taking. The idea of history taking is to narrow down the possibilities to one particular or one or two particular physiological group. Now, the physiological group that we are arriving at is, okay, since it's very clearly heard at birth, most likely it could have been a obstructive lesion or a regurgitant lesions. These are the two groups. And stop there. We don't need to try and go further.
Yes.
There's no need to split up the diagnosis further. Of course, do you rule out shunt lesions altogether?
We cannot rule it out, sir.
Why? You said PVR is high, so a shunt lesion should not be audible. Now you're telling we cannot rule it out. Why? Can you tell me why? What is the time course of PVR fall?
The PVRI in a normal neonate falls by 4 to 6 weeks, sir.
So you mean to say the PVR remains at systemic level till 4 weeks or 6 weeks?
No, it starts dropping from birth. It reaches the normal level by 4 to 6
weeks. Give me the time sequence. When
that
does
is
the
very
fall
important.
Start?
With first breath, then days. So that way we talk. We don't 4 to 6 weeks are very, very late now.
Yeah, they are talking about when the PVR comes back to normal. We are not talking of PVR dropping from systemic level to subsystemic level.
Yes.
The PVR drops as soon as the lungs expand.
Yes, at the first breath, the PVR starts dropping as soon as the child is born.
So that's only a relative statement. That shunts will not be heard at birth is a very relative statement. It can be heard at birth because the PVR drops with the first breath.
Yeah, 50% fall with first breath. So it is so significant.
The shunt starts very early. Very early. Now tell me which will be heard at this very early in life. Small shunts, a small defect or a large defect?
Larger defects will be heard.
The answer is opposite.
Small.
The smaller the defect, the more the pressure difference. There are two things which determine the murmur. The size of the defect, therefore the pressure gradient from left ventricle to right ventricle. The other thing which determines is the PVR, which determines the flow from left ventricle to right ventricle.
Yes.
The flow will depend upon PVR, but the murmur may occur with gradient. Now the 50% falls, so some flow begins to occur, but the flow has to occur from a systolic pressure of 80 to a peak pressure of 60, 40, 50. We don't know. If it's a large defect, both the pressures will be equal. So there will be no murmur. A small defect, this pressure will be 80, this pressure will be 50. It won't be normal, 50, but there will be a murmur. You understand?
Yes.
So the murmur becomes audible very early, and the murmur may be more better audible in a smaller defect than in a larger defect. Right. Okay. So this slide I would write as this: since the murmur is heard very early on, I would consider obstructive lesions as well as regurgitant lesions, but I wouldn't rule out a shunt lesions, because the shunt lesions are the commonest lesions in cardiology.
Yes.
Okay, whether you like it or not, VSD is the commonest lesion. So we have to keep that in mind as a differential diagnosis. Okay.
Yes.
Now, why should obstructive lesions cause breathlessness?
If there is increased obstruction and the outflow is compromised, then it can cause breathlessness. Or if because of obstruction, the EDPs, if they increase, then it can cause pulmonary venous hypertension and cause breathlessness.
So I think the first statement is not correct. No? Even if the obstruction is very severe, it cannot cause breathlessness by itself. Aortic stenosis cannot cause breathlessness by itself. It has to raise the LV-EDP. It has to raise the LA pressure. And then only the lungs have to develop higher venous pressure. The lungs have to become stiff. Then only there can be breathlessness. So you cannot have breathlessness just because it's a severe gradient. Right? So that you can. Whereas regurgitant lesions, like mitral regurgitation, aortic regurgitation, are much more commonly raise the venous pressure, LV-EDP rather.
LV-EDP is
Good. So we can go forward then. So was the child on any treatment? You never told me about treatment.
Child was not on any medication, sir. Only on yearly follow-up.
Okay. So what sort of exertion did the child do? You said child became breathless on exertion.
Hurried breathing, it was on playing, sir. It was just compared with the peers.
Mm-hmm.
So on playing, it would feel the child would have hurried breathing.
Okay. Would you grade this dyspnea?
It would be mild. It would come to class 2.
Which classification will you use here?
Ross, modified Ross classification.
Modified Ross, okay. Right. So you have to be very sure what severity you're talking. So it's a fairly mild dyspnea, but okay. Go ahead. We'll accept that now.
Coming to the physical examination, the child was alert, conscious, and playful. The weight was 14.1 kg, which was between the 50th and 75th percentile, and the height was 90 centimeters, which was 25th percentile. Coming to the vitals, the pulse rate, it was 108 per minute, regular. It was normal volume. There was slow rising. The right radial pulse was felt higher volume than the left. There was no radial delay or radiofemoral delay. The BP, the right upper limb was 98 by 60, left upper limb was 86 by 54, right lower limb was 104 by 64 Hg, and the left lower limb was 100 by 62. The respiratory rate was around 24 per minute. The saturations were 98% on room air. The temperature was 37.1 degree. JVP was not raised. There was mild pallor. There was no cyanosis, icterus, clubbing, edema, or lymphadenopathy.
Okay.
Coming to the head-to-toe examination, There was no dysmorphism, no thoracic spine back abnormalities, no features of Williams syndrome, no peripheral signs of AR.
Now, can you go back to your previous slide once more? Sorry, one question. You said right upper limb pressure is 98 and left upper limb pressure is 86.
Yes, sir.
Is that important, or is it significant, or is just variation? Maybe you took it at different times, or what?
Up to 10 is normal in up to 10 is normal. If it is more than 10, it becomes significant. So right upper limb, there was significant increase than the left upper limb.
Okay. What about the carotid? They were also different?
The carotids...
Right carotid, left carotid.
The right carotid was better felt compared to the left carotid. Better, the volume was slightly higher because the right radial pulse also there was slight higher volume than the left.
No, but carotid you are not described there. Did you note that?
Yes, sir.
Okay. Right. Okay. Go ahead. So it is just over 10. It's not. I mean, just beats the margin of 10. 12 millimeters.
Yes.
You think it could have been just the time difference? If you record BP once and then record BP, by the time you go to the other limb, it will be 5-minute delay. Could be there.
Yes.
No, you should not say yes. If you are convinced about your palpatory finding, you should not say yes. I'm trying to test how confident you are with your palpatory pulse palpation. Pulse
was definitely higher compared
then to... Then you should not say BP could be due to variation. Why are you saying yes?
It is significant only.
Then stick to that. You don't sound confident, but...
No, sir,
don't wait now. I'm not ragging you. I'm just telling you that you have to sound confident in the exam. Okay, good. Go ahead.
So head to toe, there was no dysmorphism, no thoracic spine or back abnormalities, no features of Williams syndrome, and no peripheral signs of AR. Coming to the CVS examination, coming to the inspection and palpation, trachea was central. The chest appeared to be symmetrical. Apical impulse was at the left fifth intercostal space at the mid-clavicular line. It was well localized, sustained with medial retractions which looked like a LV apex. There was no left parasternal heave, no thrills, no palpable heart sounds, opening snap or ejection click, no visible scarce sinuses or dilated veins.
Okay, what opening snap are you talking about? You're talking about mitral opening snap? Do you feel an opening snap? Go back. No palpable heart sounds? Okay, I accept that. Second heart sound and third heart sound not palpable, I accept. Do you ever palpate for opening snap and ejection click and all?
It's an auscultatory finding.
Then you're telling me palpation.
The message is don't overdo the things.
Yeah, don't overdo and
not too smart
don't do it mechanically.
Yeah.
Okay.
Percussion, the left heart border corresponds to the LV apex. The right heart border corresponds to the right sternal border. The left second space was resonant. The upper border of liver dullness started from the right fifth intercostal space.
Okay.
The auscultation, the S1 was normal. S2 I felt was single. No third heart sound or fourth heart sounds. No clicks or opening snaps were heard. The murmur, it was a grade 3/6 harsh, crescendo, decrescendo, ejection systolic murmur with late systolic peaking. It was heard best at the right upper sternal border, which moved up to the first intercostal space also. Radiating to the carotids, it was more in the right side than the left side, and it was best heard in the expiration with the diaphragm of the stethoscope. There was no early diastolic murmur.
Right. Now tell me, it was the second right intercostal space, okay, up to the first intercostal space. Was there a thrill anywhere?
I could not feel any thrill, sir.
Did you feel where all did you feel?
in the carotids, then the aortic space area, and the upper sternal border.
With this description so far of your physical sign, where else should you palpate for thrill?
Carotid, but it was.
Where did you feel for the carotid?
Between the two sternal heads, sir.
Between the two
heads of the sternocleidomastoid, sir. Between the two heads of the sternocleidomastoid, that was we felt the carotid.
You mean to say at the lower end of the sternocleidomastoid muscle?
Up till the angle of the jaws.
Okay. But the best place to feel carotid is at the level of the cricoid against the cervical spine, isn't it? Yes. Here, somewhere in the mid.
Posterior border of the
sternocleidomastoid are here. Sternal and trabecular head are at the lower end of the sternocleidomastoid muscle. There, the carotid is rarely felt because it's deep down. Now, you should feel for a thrill in the suprasternal notch. See, all your physical signs, you are leading to me towards something obstructing in the ascending aorta, isn't it?
Yes, sir.
Now, the best place to feel a thrill for the ascending aorta is either the right second intercostal space or the suprasternal notch or just above the medial end of the clavicle. That is not at the carotid location, it's at the root of the neck.
Yes.
That's where the best thrill of supravalvular AS is felt. Very low in the neck or high in the chest. Okay. Now, did you feel in the suprasternal notch?
I couldn't feel any thrill, sir, even in the suprasternal notch.
Supraclavicular region?
No, sir, I didn't get any thrill.
Okay. Right, okay. But I would, okay, go ahead. So you did not feel a thrill. So the murmur remains grade 3, not grade 4.
Grade 3, sir.
Okay. So then what did you do? Best heard on expiration with the diaphragm of a stethoscope. Right. So why did you look for an expiration? Do you really expect this murmur to become grade 4 on expiration or what? You are looking for an increase or decrease?
Increase.
With inspiration and expiration.
Increase.
Okay. See, I know we are taught that right-sided murmurs increase on inspiration, left-sided murmurs should increase on expiration. But again, don't describe it mechanically. Okay. Aortic murmurs don't change much on respiration. If you maybe record their intensity by graph and all, you might show some difference. But to the normal human ear, they don't change much on respiration. The murmur is already grade 3, well heard, clearly heard. It's long crescent, or let's say long loud murmur. 3 is a loud murmur. Okay, so I wouldn't say expect it to increase further on expiration. So don't need to describe that once you're sure it's an aortic murmur. Only venous murmurs, right-sided murmurs, where you're trying to differentiate in right-sided or left-sided murmurs, the respiration is important. Okay, so did it radiating to the carotid more on the right side?
Yes.
Not heard on the left side?
It is heard both, sir, on in both the carotids, but it was more heard on the right side than the left side. Okay.
Okay, good. Go on, next.
So other system examination, respiratory system. It was abdominothoracic respiration, bilateral equal air entry, normal vesicular breath sounds heard, no added sounds. Per abdomen, it was soft, non-tender, no organomegaly, bowel sounds were present, and the liver span was 8 centimeters. CNS examination, the child was conscious, there was no focal neurological deficits.
Okay. Now, tell me, you said, no, don't go to the diagnosis. You told me that the pulse was slow rising.
Yes, sir.
Remember? Which pulse was slow rising?
The radial pulse, sir.
Okay. Is radial pulse a good pulse to examine for slow rising or brisk rising or whatever character of the pulse? Is that a good pulse?
Brachial would be a better one.
Which one?
Brachial.
Is brachial the best?
For character, we specifically say which pulse to see.
See, we should not go radial, brachial like that. Generally, we differentiate between central pulse and a peripheral pulse.
Yes.
That's where the difference comes. Then you can answer that question easily.
Central
Which is better for character of a pulse?
The central pulse.
Central. Why? What happens to the pulse as it travels from central to periphery?
Amplification occurs.
Oh, that's a partial answer. So you will also get only partial mark. Don't give me partial answer. What amplifies, how it amplifies, everything you should tell.
Peripheral amplification of the pulse occurs as the pulse track.
What pulse? What part of the pulse? I shouldn't have to ask so many questions. You should give me in one sentence. What part of the pulse accentuates as it goes peripherally?
The curve of systolic ascent, descent, and there is a wave. There is a something when you like if you have been to cath lab very clearly, we need to remember that much. And amplification.
What pulse is part of the pulse? Systolic amplification. Systolic pressure amplifies, isn't it?
Yes.
Why?
The waves are reflected, so...
Okay, what waves are reflected? Light waves, sound waves, arterial pulse. You're right. What gets reflected? Come on.
The pulse waves are reflected back, sir. So the systolic...
From where is it reflected? From the edge of the bed?
From the periphery, sir.
What periphery? What is periphery? Periphery bed or periphery of the room? What periphery?
Arterioles.
Arteriole. Very good. So when the pulse traveling down the wall of the artery meets the area of resistance, that is the arteriole, it gets reflected back. That reflection travels back in the arterial wall, and somewhere it meets the next pulse coming down the arterial wall. So the next forward going pulse and the returning reflected pulse summate. They meet each other and strengthen each other. So the systolic part of the pulse increases. Therefore, the recorded systolic pressure also increases. Right?
Yes.
Now tell me, will the upstroke be normal in the periphery in a case of aortic stenosis?
Upstroke is can be normal, sir.
Can be normal because it can be slow rising when it began at the aortic valve, but by the time it reached the periphery, it is falsely becoming accentuated by reflected waves.
Yes.
Therefore, the character should not be examined in a peripheral pulse. It should be examined in the carotid pulse.
Yes.
That's the only pulse, central pulse which is accessible to you.
Yes.
Okay. So now in this case, tell me the character of the central pulse.
Slow rising. It was one second.
But I'm sure right side was not slow rising. You said right side is very strong on the left side. There might have been a difference in the character on two sides. Possible.
Yes, sir. There was the volume was higher on the right side compared to the left, and there was a slow rising pulse. The pulse was sustained, sir, and then there was. Okay.
So okay. I mean, I don't know what the diagnosis will come to it, but if you really have a supravalvular AS, sometimes the right-sided pulse may not show slow rising at all. It may look actually very strong and bounding pulse. The upstroke may be very sharp, whereas the left pulse may actually be may show a slow rising character. Okay, so you have to, if you have two different characters, the two carotid, you have to describe it separately. That's the message I want to give it to you. And never peripheral pulse for carotid, for character.
Yes.
Okay. So right now, go to your to summarize your finding. You had a 2-year and 11-month-old child breathlessness, and you had slow rising pulse, you think, and you had a stronger pulse on the right side, and you have a grade 3 murmur. Am I right?
Yes.
No additional sounds anywhere.
No, sir.
Okay. Go ahead.
Diagnosis, it was situs solitis levocardia, severe supravalvular aortic stenosis, not in congestive cardiac failure, in sinus rhythm, NYHA class 2, no evidence of infective endocarditis.
So, why aortic stenosis? Why supravalvular aortic stenosis? And why severe? You have to justify all three parts of your diagnosis.
So I got a grade 3/6 it was a crescendo decrescendo systolic murmur, sir. So that will in the aortic region. So it was so most likely it's a aortic stenosis. And then it was radiating to the carotids with the right side carotid better. There was more radiation to the right side carotid than the left. So I would think it was a supravalvular aortic stenosis. Coming to the severity, there was a late systolic peaking, and I felt there was only a single S2. So based on that, I think I have kept it as severe supravalvular aortic stenosis.
Okay. So just because right side pulse is felt better than the left side pulse, you are saying it is supravalvular. Yes. That right?
Sir, there was no click also. Ejection click was also not heard to call it any aortic, not valvular.
So that rules out that you think that is against the valvular ES.
Against valvular ES.
Okay. Can you tell me some forms of valvular stenosis which does not produce a click?
If there is bicuspid aortic valve which are fibrocalcific, then it might not produce.
We are talking of a 2-year-old child. No? We are not talking of a fibropath age group. We are not talking of that. We are talking of a newborn child to young age only. No? Can you have a valvular EAS and still not have a click? What is the minimum requirement for a click? The valve leaflet should be mobile, no?
Yes.
They should move and they should try to open and form a dome. Then only it can produce a click. Is there any congenital aortic stenosis where the valve does not move or it does not dome?
Unicommissioner.
Yes, acommissural or unicuspid valves. There have been no click. They're almost like a hole in a diaphragm. Okay. So commonly aortic valvular stenosis has a click. I take that point. Now, what do you call this effect? Right-sided
And
okay. I mean, why does it occur?
Because there will be a stenosis in the STJ junction, and because of the hourglass shaped narrowing, the blood flows more towards the right innominate artery, and this causes a quanta effect where it is better felt in the right side carotids than the left side.
Okay. So it's not a character of the supravalvular ES. It's more a fluid physics phenomena where when a jet going through a narrow orifice often tends to cling to the wall of a distal chamber. It's more a fluid physics. Okay. Have you heard of this phenomenon in any other place in the heart?
Including regurgitant lesions like TR, MR, they go towards the wall.
Very good. Yes. In MR, often it clings along the posterior wall of the LA. Yeah, like that's also described. Yes, that's again a narrow orifice and with a large cavity beyond that, it clings to the valve. Okay, so you're basing your diagnosis on that.
Yes, sir.
But you said you didn't have any features of Williams syndrome. Then what sort of supravalvular do you think it is?
It can be a non-familial condition where the child has normal intelligence and normal development with no Williams syndrome, sir.
Okay, non-genetic forms of supravalvular AS. Right. Why don't you think of the valvular AS with some arterial obstruction? Suppose I postulate that this patient probably has carotid artery or innominate artery stenosis. I think I'm telling you there's no aortic stenosis at all. It's all innominate artery stenosis. I'm telling right innominate artery, no? I think that is stenosis. I'm just asking you to think.
The symptoms of the child, there should not be any.
Okay, agreed. Should not produce cardiac symptoms.
Cardiac symptoms should not be there.
What else?
And if there is stenosis, then there'll be claudicatory pain.
Claudication where? In the head? No, in the arms? That's not necessary. In a 2-year-old child, what exercise does he do with the arm?
Blood pressure? You have given a
blood pressure. There is a difference.
Was higher than left.
Right side.
I told you stenosis, and your BP was actually higher in the right arm, no?
Yes, sir.
It's
right, a higher BP with a louder murmur on that side.
Yes, sir.
Correct?
Yes.
Yeah, that's the difference, no?
Yes.
In an obstruction of the artery, you get a higher murmur with a lower BP. In Coanda effect, you get a higher murmur with a higher BP.
Yes.
You understand the difference?
Yes. Yes.
So here you have a condition where the pulse is strong, but the murmur is also loud. Okay. And secondly, how will the innominate artery narrowing produce slow rising pulse in the left carotid?
Sir?
Innominate artery lesion will not produce a change in the character of the left carotid pulse.
Yes, sir.
Okay. Sorry. How do you know it is congenital aortic aorta narrowing? Are there any other causes of supravalvular aortic stenosis that you are aware of?
Congenital, because they heard the murmur at birth.
Okay.
Because of that.
Okay.
Congenital.
Tell me, are there any other conditions which can produce supravalvular AS? Not in this age group, any age group. What are the other causes of supravalvular AS in general, not this age group? You haven't heard of any other cause of supravalvular AS? Takashu arteritis?
ELN arteriopathy can also cause.
What arteriopathy?
ELN arteriopathy, sir.
I didn't hear that.
If there is a defect in the elastin, then so
I'm not sure about that.
That is Ehlers-Danlos syndrome or
Ehlers-Danlos syndrome. Okay, but those are dilatation lesions.
Yeah.
Those are all dilatation lesions. The
first thing, Takashu
aorta arteritis.
Lowy-Diggs syndrome.
So the two common causes.
Want to say that she wants to say probably the tortuous arteritis syndrome.
Yeah.
Tortuous arteropathy, you want to say?
Yes.
No, again, tortuous arteropathy does not cause aortic stenosis. It causes tortuous aorta, but it can cause multiple peripheral pulmonic stenosis. I don't think it causes supravalvular AS. No. It can cause tortuous and dilated aorta. Now, the two other, I wouldn't say common, but the other two other causes of supravalvular narrowing are Takayasu's arthritis and atherosclerotic. In elderly people, just atheroma in the ascending aorta with calcification can cause supravalvular AS. So I think these are the only three common causes. All the collagen disease and the elastic syndrome are all dilatation disease. Now, obviously, this child is not in the age group of Takayashu or the atherosclerotic narrowing. So I'm with you with this supravalvular congenital origin. What features did you look for Williams syndrome?
First, the developmental, coming to the history of it, developmental milestones were appropriate. So there was no MR or anything. Then
there was no MR. What did you say?
No
was mentally normal. No required.
In a cardiology case discussion, if you say MR, I have only one. I don't know mental. I don't assess mental status at all. So no short forms, please.
Yes, sorry. Then,
like in Williams syndrome, they are more of mentally retarded or something else.
Yeah.
So they have very typical personality, not retarded. They are
hyperactive.
delayed milestone नहीं होता है.
That's not the primary thing, no? That's what Dr. Tomer is saying.
Hyperactive.
They are more of hyperactive child.
What else?
Elfian faces, okay. Then platulous lips, smooth philtrum, upturned nose.
Okay. You've seen a elfin face before? You've seen a patient with supravalvular syndrome?
Yes, sir.
Okay. So this patient's faces was not fitting that.
No, sir.
Okay. Let's assume for the time being that he may have features of supravalvular syndrome. What else would you look for?
Peripheral pulmonary stenosis in case of it is.
Louder.
PS, sir. Pulmonary stenosis.
Peripheral PS, yes. What else? What else can happen in supravalvular AS?
Any arteriopathy if it can occur. So I will try to rule out arteriopathies.
Like?
Ascending aorta dilation, aortic root dilation.
Okay. What else? Not more known for stenosis rather than dilation. The stenosis can occur somewhere else also.
Middle aortic syndrome.
Middle aortic syndrome, yes. What else?
Coronaries also.
No, coronaries the last. Renal arteries, abdominal aorta.
Renal arteries, then cerebral arteries.
Okay. So now answer my question. What else will you examine?
Bruit, if it is present.
Yeah, abdominal bruit, bruit in the renal angle.
Renal angle bruit.
And of course lower limb pulses you already told.
Yes.
So I didn't find that in your abdominal examination. A good student should think of this, go back to his notes and add in the per abdomen finding. There's no bruit. I know you have added no sign of the syndrome, supravalvular syndrome in the history, in the physical examination, but you forgot to add no bruit in the abdomen. So that you should always do at the end of your examination, go back and add whatever is relevant.
Yes.
That makes your presentation more complete and more impressive. Okay?
Yes. Right.
So not in congestive heart failure, not in sinuses. Why do you say no in sign of infective endocarditis? You're worried about infective endocarditis in this patient? Did he give you a history of fever? Did he present with fever at any stage and all that? Anyway, I know you people write routinely in every case no sign of endocarditis. Those are not common complications of. Is endocarditis a common complication of vascular stenosis?
No, sir.
Very uncommon, extremely uncommon. Okay. So next what? What would you like to do?
Investigations.
What? Tell me what investigation, not investigation.
We'll be getting the X-ray, then the.
Yeah, go ahead. Can we have the X-ray there? Okay, we have the ECG there. Go ahead. Come straight to the point. What do you want? What do you want to see here? And tell me it is there or not.
I would want to search for left ventricular hypertrophy, sir.
Yes. Is it there?
It is not. It's not there, sir.
It's not there. Okay. So anything else you want to see in the ECG?
No, sir. It's a normal axis.
You would also like to see the left atrial enlargement. No? Whenever you expect left ventricular hypertrophy and you don't find it, left atrial enlargement is also an indirect sign of left ventricular hypertrophy if the mitral valve is normal. Okay, so is there left atrial enlargement?
Sir, no, sir.
Doesn't seem like it. Okay, agreed. So ECG, would you say it's normal?
It's normal.
Okay. So are you surprised? Are you disappointed? You want to change your diagnosis?
No, sir.
But there's no LVH and you are diagnosed severe AS. You don't want to change your diagnosis.
No, sir.
Yes, your answer is right, but you're not confident. Come on, tell me the reason why you're saying no, sir. Because LVH, ECG is helpful in diagnosing LVH if it is present. If ECG features are not there, it doesn't rule out LVH. Okay. ECG is helpful when it is producing some changes. Absence of a change is not very helpful in ECG. Okay, so ECG is not much help. Go ahead, next.
The X-ray of the child shows situs solitus.
Shruti, is there any other finding in ECG which you like to see? What is other common abnormalities with maybe a supravalvular aortic stenosis and maybe a Williams? What are the other findings which you expect in ECG? LVH is definitely, and you should be knowing, as Sir is saying, about the sensitivity of the ECG of the LVH, right? So any other thing which can be present in the case of supravalvular aortic stenosis? Can there be
coronary obstructions can be present?
So how will coronary abnormalities present in ECG? Yeah, not very common, but these are the things which you have to see.
Elevations.
So depolarization or repolarization abnormalities. Okay, that we have to see. Okay, sure. Just for completion, I ask. Yeah.
Yes, sure. Go ahead.
Coming to the X-ray, it is situs solitus, levocardia. There is no cardiomegaly. The QP appears to be normal. There is no dilation of the ascending aorta. It appears to be a normal X-ray.
You have a patient who is breathless, according to you. You have a patient in whom you have diagnosed severe aortic stenosis. So you have to look for very subtle signs also. So can you give me negative findings, or if you say normal, you have to tell me specific negative findings, so I should know what you look for.
No pulmonary venous hypertension features.
Okay, go on. What?
No ascending.
Did you look for left atrial dilatation?
Yes, sir. There is no left atrial dilation, sir. The carina angle is acute only.
Carina angle is one sign. What else? Can you see a double density there?
No, sir. There is no double density.
I can see a double density from here. I don't know what the others feel.
Yes, sir.
Yes, sir. It is. So, Suti, what are the signs of LA enlargement on the X-ray? That is what sir wants to ask.
Increase in the carinal angle and presence of double density, and
so LA is a posterior structure. It can enlarge in a superior direction. It can enlarge in a posterior direction, and it can enlarge in a lateral direction, left and right. So all these signs you have to go in an order whenever this question is asked. If it enlarges in a superior direction, what will happen? The carinal angle is going to become more. If it is going to enlarge in a rightward direction, then it of course puts a double density of the RA shadow of the LA shadow. If it enlarges in the leftward direction, what will happen?
The left cardiac border.
What part of LA forms the left cardiac border?
The appendage will be seen like the left border. There will be straightening of the left border.
Yeah, so straightening and dilatation of appendage leads to straightening. And what if it directs in a posterior direction? What if it enlarges in a posterior direction? How will it manifest?
If we see in the lateral X-ray, there may be any
Absolutely. So AP view, you have to comment on left and right, and maybe a superior. Posterior part you may not be able to see. Posteriorly, it will get a barium shadows. All those things are there, right? Okay.
Yeah, so absolutely. So you have to think of all the four directions, and in this case, you have to. I think there is a shadow within shadow on the right cardiac border. So it's very suggestive of the left atrium inside the right atrium. You can see the dense shadow then. The carinal angle should be less than 90 normally. I would say this is about 90, and the left. I think I would go for left atrial enlargement in this case. Secondly, I don't agree with you that the upper lobe veins are normal. They do look a little prominent to me on both the sides, vertically going up. Now, all these signs are very soft signs. They're always interpreted in the light of your history and physical signs. Okay, right. So, does this X-ray help you in any way?
If there is left atrial enlargement, then we can tell that there has been increase in the LVEDPs. So it could have been like severity.
Okay. It does help you in the assessment of severity, but it does not tell you much about the actual diagnosis.
Yes.
All right? Okay. Go on. Next.
Can you predict LA pressure with respect to the X-ray? If you have to give an X-ray, would you be able to predict LA pressure in general? Is there a way? Can you classify PVH? Pulmonary venous hypertension? You said upper lobe vein is prominent. What is the normal LA pressure?
Normal LA pressure will be around 5.
5?
5 to 6 can.
No.
So when do you call a pulmonary venous hypertension?
If it is about 10, then we call it as pulmonary venous hypertension.
So I think this is a very, for all the listeners, this is among the most important sign. You have to know the classification of pulmonary venous hypertension. Please go read it. And you can classify the pulmonary venous hypertension as per the radiological findings. And examiner will ask you to predict the pulmonary venous pressure.
Absolutely. Yes, I agree, Niraj, absolutely. So, go ahead. You must know the normal hemodynamic pressures. The normal RA pressure is said to be between 5 to 8. So the LA pressure has to be higher than that. 8 to 10, 8 to 11, 8 to 12. Generally, PVS starts from 12 onwards. Go on. Next.
Coming to the echo,
Okay.
it shows situs solitus. The When we come to the abdominal aorta tracing, it is pulsatile. Then this is the apical four-chambered view. Then showing later the outflow tracks. This shows
So, Spruti, whenever in exam, no, you have to comment the view.
this
You
is
should proceed in normal.
apical four-chambered view. Later showing the five-chambered and later it is a posterior anterior sweep in the apical chamber in the apical region, and the last pulmonary arteries are being shown. The right RV outflow. So all the chambers, the LV appears to be slightly more dilated compared to the RV. Then we are not able to exactly see the aortic stenosis in this view. There is no RV outflow obstruction.
Okay.
What is with your clinical history, what is the evidence you wanted to see on a echocardiography?
I wanted to see LV hypertrophy on the echoes.
Okay, that is not there. But your LV dilatation, you are saying. What is the objective evidence of LV dilatation? And how do you objectively say that LV is dilated? You
So
say
usually mitral annulus will be measuring and comparing it to the tricuspid annulus. So
Okay.
the we can also check the difference in the volumes if we take a 3D imaging. So difference in the end systolic volume, end diastolic volume minus the end systolic volume.
No, you're trying to say volumes or you're trying to say ejection fraction? See, you are diagnosed a pure obstructive lesion. Which is more important, hypertrophy or volume?
Hypertrophy would be
Which is the best view to see hypertrophy?
it will be the parasternal short axis view where we can see the ventricles clearly.
Okay. Is that the view you do all your measurements of LV, IVS and posterior LV wall and all?
We'll be seeing the parasternal long axis views.
So why don't you say parasternal long axis view?
Yes,
That's the standard view. Why is that the best view? Why not apical view? Why do you always measure septum in the parasternal long axis view, but you never measure septum in the apical view? Why? Because
what is happening to the radial ultrasound beams in a long axis view and what is happening to the ultrasound beam in a apical four chamber view? That is the question.
It will be perpendicular in the apical view and parallel in the.
Oh, you're talking of a reverse. No? Where is it perpendicular? Where is it parallel?
Perpendicular in the apical, sir.
Perpendicular in the parasternal long. No, you waves go perpendicular to the septum like this.
Yes.
Here you're going along the septum. All measurements, all resolution is always best along the axial direction. Lateral direction, resolution and measurements are not accurate. Okay? So all measurements of thickness always in perpendicular view. Short axis is okay, but long axis view is a standard view for all measurements of hypertrophy. So you haven't shown us a long axis view, so that I can't talk of hypertrophy now.
Yes, sir.
Do you have one?
Yes, sir. This is more of the the LV is cut out, sir. This actually is more of the aorta and aortic root and the constriction at the STL junction. The stenosis which is present at the STL junction.
If you have to take a LVH in this view, where will you take your M mode cut? At what point? Did you have your eco posting? So your second year, I think. Did you have an eco posting yet?
Yes, sir.
Okay. So where will you took a M mode cut in this view? What is the point?
So we will be taking at the LV. So here the LV is not seen.
No, I'm saying that suppose there's a long axis LV cut, which is partially seen. Okay, you've taken a proper long axis cut. Where will you took your M mode cut?
Where?
Mitral valve level will be taking the cuts.
The mitral valve is this long. Where will you take? At the base of the AML, at the middle of the AML, tip of the AML? You're very precise.
At the base of the AML, sir.
That means the annulus. All measurements are made just below the mitral valve tips, just where the leaflet gives way to the chordae. You should not see the leaflet, but you should not be too far away from the leaflet. That is where your axis should cut the long axis view and you go into M mode. Okay. Please read up how to measure. Now tell me, you have taken long axis view, you have made an axis cut at the point I said, but will you measure on 2D or will you measure some other method? Measurement, how do you take?
M mode.
Huh? M mode. M mode.
Yes.
Oh. Why M mode is better? Why not on 2D?
The thickness can be well seen on the M mode.
Why? I'm sorry, did you say you finished your echo posting? Yes or no?
Yes.
Yes, okay. So then you should have read it. Okay, at least go and read now.
So the question is, what are the phases of cardiac cycle and how the cardiac cycle is better profiled? Is it better profiled on a 2D or is it better profiled on a M mode?
It's better profiled on the M mode, sir.
Yes.
So the correlation of the is better on M mode, no? So that is the reason that you can. Okay.
But please go and read about it. How M mode is better than 2D.
Yes.
Okay, go on, please. No, describe that aorta better. Or unless you have better views later.
Yes. This is the long axis, parasternal long axis view showing the aorta along with the root and the STL segment. The valve seems to be normal. The closure line is at the center. So it's not a bicuspid aortic valve or unequal cusp. And the aortic root is not dilated, whereas the STL segment is narrow. There is stenosis at the STL segment.
Please, no short forms. I know what STL is, but some people may not know it.
Sinotubular junctions.
Okay. Then, okay. Do you have more views of the aorta?
Yes, sir.
Okay, go ahead. Because I want you to describe that aorta better.
I don't know the short form. ST. What is STL? What do you mean by L? I thought we call. So this will be the confusion. Always use a full form, no?
Sinotubular junctions, sir. STJ.
Yeah, it is, yes. Some people call it sinotubular junction, sinotubular level. So that's why I said don't use it.
Yes.
STL for me is septal tricuspid leaflet.
This is the short axis, parasternal short axis view showing the aorta and the RVOT. So there seems to be 3 cusps in the aortic root. So the aortic valve seems to be normal.
Okay.
This is the color Doppler form of the short axis view of parasternal short axis view. This shows no confluent branch PAs, good sized, no peripheral PAs.
Don't say no peripheral P. You won't see peripheral PS here unless only the main branches, if they are narrow, you will see it. Huh? Peripheral PS may be much more distal, you will not see in this view. Okay, go ahead.
This is the suprasternal arch view, where we can see a flow acceleration at the STJ sinotubular junction.
Mm-hmm.
So Sputi, what measurements would you like to take in a case in this particular view? What objective measurements would you like to take? And which one is more sensitive for a supravalvular stenosis?
So we'll be taking the measurement of the aortic root, the STJ's
We have only 3-4 minutes.
and the valve, the root, and the sinotubular junction. So narrowing at the sinotubular junction would suggest supravalvular AS. It is possible.
Actually, objectively, the most important is the aortic root diameter, because aortic root diameter tends to increase, and aortic root diameter, and you have to take the Z-scores, but aortic root diameter is more important. Since short of time, I'll give the answer. Let's go to the next.
See, I think your description of the lesion also is not complete. No? I mean, since you know the diagnosis, you must have read the types of supravalvular AS, isn't it?
It can be diffuse or localized, sir.
Yeah. So why need to describe it for me then? You know the type, mean you should tell me the description here.
This looks like a localized. Only the there is stenosis at the sinotubular junction only, sir. Later, there is no stenosis, so it most likely is a localized.
But you know what? When you have a localized stenosis, there's always dilatation beyond that.
Again, this view, it's almost same diameter is extending. You have Z-scores of ascending aorta and those areas because root and then same lumen is continuing, no change in diameter.
One of the characteristics of discrete stenosis is the narrowing is small, but immediately because
hourglass
dilates
comes there.
That's the hourglass.
Here it doesn't seem like that.
So there's something called a tubular variety also, no?
Yes.
Okay. So you have to trace it all the way into the arch and see at what point the aorta becomes normal or dilated.
Yes.
So that would be the segment of the stenosed aorta.
Yes.
Okay, go on.
So this is the measurement at the valve and at the aortic root.
Yes, what Neeraj said was very, very important. The annulus is probably the single most important because ascending aorta can be smaller than the annulus is small. You have to first of all prove the annulus is not small. And moreover, in these cases, annulus actually enlarges because of the high pressure. The root enlarges. Therefore, the contrast between the dilated annulus and the supravalvular AS becomes even more prominent. Okay, go ahead.
And this was the narrowing at the.
How much was it? How many millimeters?
It is 9.11 mm.
Okay. Is that what's the normal ascending aorta of a 2-year-old kid? How much would you expect it to be? Roughly, I don't also know normal value, but 9 looks normal to you?
10 to 12.
Probably more. If you have seen aortic stenosis, annulus measurements and all, the newborn aortic annulus probably about 10 millimeters, and then by this time you would probably expect the annulus to be at least 14, 15, or ascending aorta to be 15 millimeters. Okay, go ahead. So what is next? Gradient.
Gradient taken showed 79 by 46. The peak was 79. The mean was 46. So,
okay. So can you describe this is okay, right. High gradient, high grade. Go on.
high grade. This is still the suprasternal arch view, sir. Again, there is no dilation of the aortic root. Looks to be there is only flow acceleration at the sinotubular junction. There is
You have a measurement of the arch, top of the arch. No problem. Okay, we are running out of short of time, so go ahead.
So what is your plan with this patient? You need another imaging, you are sending for surgery, or you are waiting? What is the indication to operate? Oh, sorry, what is the, are you satisfied with your evaluation and what is your plan?
I would want to check out the entire of the aorta to check if there is any more any stenosis and where it becomes normal. So I would want a further investigation for this child because this looks the
Say what imaging? No, don't say imaging.
CT would be preferred.
CT.
CT cardiac.
Okay. Specifically, you want to study the whole aorta.
Whole aorta.
Agree. What else you want to study? Quickly.
The coronaries also.
Coronary arteries. Okay. Yes. And of course, something else you already told me, pulmonary arteries and abdominal arteries. Okay. Then what? You have shown that and you have arrived at a diagnosis of supravalvular AS in this case. What next?
As the gradients are more, this has high gradient, so we would plan for surgery for the child.
Oh, that's the wrong. You never say the gradients are high. Gradient can be high due to many factors. You should say something else.
The severity of the stenosis is higher.
Yes.
So
the gradient is not the same as severity.
Yes.
Right? You understand?
Yes.
The severity of aortic stenosis is judged by its effect on the heart, its effect on the pulmonary venous pressure, its effect on the patient. So in this case, it has produced symptoms. It has produced LA enlargement, and therefore it is hemodynamically causing trouble. And it is corroborated by a high gradient.
Yes.
Okay. So anything particular about surgery? Anything specific? Any specific information would you like to give the surgeon from your investigation? Or you just tell him, so probably operate kar do.
There might be, it might not be localized and it might be diffuse.
It's elongated, it possibly an elongated segment. That's what we feel on echo.
Yes.
So we saw it's a tubular narrowing. But of course, it will be subject to confirmation on CT angio because a tubular narrowing is much more surgically difficult problem to correct than a localized. Okay. Can you do a balloon dilatation?
Balloon dilatation, no sir, because this is not valvular AS and supravalvular we generally do not do balloon dilatation and this is not localized also, this is diffuse. So this balloon dilatation cannot be done.
So yes, not a localized lesion. In general, supravalvular AS, the tissue is not dilatable. Balloon best works as a discrete membranous or fibrous ring. This tissue is not like that, and therefore it's unlikely to work. So surgery would be the best option. Okay. Anything else you want to advise the patient?
So two things, but what is the surgical ones? What are the surgical option? And second, what will you prognosticate the patient? It has already been discussed. One subtle point has been discussed, but these two, if you can re-emphasize, one, surgical options, and two, prognosis.
If it is a localized, then it would be easy.
Prognosis is localized and versus diffuse. Okay. Second prognostic feature in supravalvular.
The coronary arteries would be the
involvement of coronary arteries. Third. Most important, biventricular obstruction. associated biventricular obstruction. These are the three prognostic features, considered three prognostic features for a supravalvular aortic stenosis that help you guide the patient.
It's
What are
very
the surgical
genetic
options?
association.
Genetic association. If any,
Because it's very common.
Yeah.
Williams and what has been discussed. What are the surgical options?
can go for bronze correction, where it's a 3-part correction of the
Myoplasty, bronze, or what else?
Magoons, bronze, or it can be doties.
Okay. Do people do Ross for this? Is there a condition where Ross may be needed?
It will be done in AS, sir. Supravalvular is not preferred. If there is valvular, then we'll go for AS, for Ross.
At times there is a significant
Tethering.
dilatation, and Ross is one of the things. So you have to, whenever Ross is, in case the patient is a candidate, then you have to consider for a pulmonary valve assessment also, which is very important. I think these are the mentioned prognostic features.
Okay, I think we are already 20 minutes over.
Okay.
Wonderful case, Purti, and congratulations. It's your first case presentation you have faced, Dr. Raghavan and Neeraj.
Thank you.
So she's has done her first year, completed her first year. So very good presentation from
Yes,
your
Purti.
side for the first year for such a junior. Very well you have presented. And best wishes for